Next on our cards, we have Dr. Manjula Jayakumar. She will be talking to us on tips and tricks in assessment of binocular vision, ophthalmologist perspective. She is a senior consultant in charge of pediatric ophthalmology at Agarwal Eye Hospital, Chennai. Undergraduation at Kilpauk Medical College, postgraduate diploma in ophthalmology and diplomate of National Board, New Delhi from Shankar Nethralaya, Chennai. Best PG student of Shankar Nethralaya, she was bestowed the Ramakrishnan Endowment Prize. Fellowship in ICO accredited to UK, and she passed with distinction. Fellowship training in pediatric ophthalmology from Shankar Nethralaya and 20 years and more of clinical practice in pediatric ophthalmology post-fellowship training. Dr. Manjula is interested in research and academics with special interest in surgical innovations, publications in both international and national journals, surgical innovation for MED published in JAA POS and modified fade-in operation, a novel surgical technique published in IJO, which was awarded the best of IJO publication. So we are starting the session for Dr. Manjula Jayakumar. I invite her to present her talk.
Thank you for the kind introduction.
Ophthalmologist perspective on
Manjula, I'll share my screen. Can you stop? Yeah. Is it visible? Is the slideshow visible?
Yes, it is visible.
No, but it is in the form of slideshow, or how is it?
No, you put it on the slideshow. Just click on slideshow.
Okay, one minute. It's not responding. Just a minute.
And you just click on resume slideshow.
No, but I'm not getting the arrow. Just 1 minute. Just a minute. I will.
No problem, ma'am.
I just call my. Okay, it's coming from. Is it now coming? No. Just 1 minute.
Ma'am, I think you need to unmute yourself.
Okay, 1 minute. We'll go to the. Yeah, 1 minute. I have these things opening. Share screen. Which two I expect? I'll go here and. No, I didn't put in that one. Slideshow.
it's not working. Your presentation is not corrected. What will be doing? Don't say that. Can't even see your mouse from the angle.
Save, no?
Don't say. Put it as don't say. Like, and open the presentation.
How do I open?
Now the desktop, rather than you save the presentation. And now put it as search.
Now is it clear, Rachula?
Yeah, it's clear, Dr.
I'm
Manjula. Carry
sorry,
on.
I'm sorry for this thing. There was some problem. Okay. Thank you for the invitation. And as ophthalmologists, we are all worried mostly about the aspect of vision. What is the vision in each eye? But today, I'm going to emphasize more on binocular vision. My talk today is on the tips and tricks in binocular vision assessment. So if you look at what is binocular vision, it is basically a balance between patient's refraction, phoria, vergence, and accommodation. Now, if you look at the pediatric population, 8% of the problems are due to refractive errors. 4 to 5% is because of amblyopia. 2 to 4% is because of strabismus, but a huge 20 to 30% occurs because of binocular problems such as convergence and accommodation anomalies. Now, there are a lot of presenting symptoms these patients present with, but the most important symptoms that you need to ask are the presence of asthenopia, headache, and words that move or float. So these are the important symptoms that you ask your patient if you suspect them to have a BD problem. And what are the important things in history taking that you need to ask? The first thing is the age of onset of the presenting symptom, the speed at which the symptoms present, and the frequency at which they occur, apart from the other things which I have put in this slide. And the risk of BD problems increases when you have birth issues in the child, trauma which can be accidental or non-accidental, and systemic diseases. Now, is your child in your chair who has come to the OPD suffering from a BD issue? How do you know that? The risk is if the patient has a parent with strabismus, it is 12%. The parent has both strabismus and hypermetropia, the risk increases to 18%. The child per se has a very high hypermetropia, the risk is about 50%. And if the child has got both hypermetropia and strabismus, the risk increases to 86%. Now, when will these symptoms occur? A decompensating phoria usually occurs if it is esophoria or intermittent convergence squint at 3 years, if it is exophoria or an IDS at around 5 to 7 years, if the child says the symptoms are annoying, it means that it is a recent onset problem. And if you look at incompetency of phoria in a child, think of CCDD. Diabetes, grave stroke are an older population, but in a child, it is incompetent phorias are because of CCDD, and competent phorias are because of decompensation due to stress, fatigue, or illnesses. Now, before you go with your examination, you need to teach your child to differentiate between blur versus diplopia. Now, this is not strabismus assessment. What we are doing is BD assessment. So it's all about blur points and doubling points. So you need to teach your child or even your adult patients what is blurring and what is doubling before you proceed with your examination. And one good exercise that I would teach all of you to do is to assess your corrective movement. When you assess your corrective movement, you start estimating your phorias. So this is a video. See, I'm putting 2 prism base out prism, and you are assessing the refixation or the corrective. A 2 prism base out will produce a very small movement. See, as you increase your prisms, you see the refixation movement gets more bigger. So start estimating your phoria. You keep doing it to normal people, then you will know how much is the abnormal phoria that you're estimating. So see, as you go to a 10 prism, more is your excursion movement. So that's a very good way of estimating your forias. And the two important tests which is needed in BV assessment is cover uncover test and alternate cover test. So what does a cover uncover test show you? A cover uncover test will show you larger forias or intermittent forias. You give an accommodative target, you place a cover for about 4 to 5 seconds, and then you remove the cover. See this. This is larger than a foria. It's a small intermittent tropia. Maybe this is a foria of about 12 to 14 prisms. So this is anything more than 10 prisms, and which opens up on your cover uncovered test is a sign of an intermittent tropia. So this is how you will assess. We are not thinking about manifest tropia. Manifest tropias will not have any binocular single vision. Then the next test that you will do is an alternate cover test. What does alternate cover test show? It shows you will quickly shift the cover between the two eyes. It will show you the presence of only forias. So if a patient has foria, you can dissociate your foria and you can get it on your alternate cover test. You quickly switch covers. This particular patient or subject did not have any foria. The next thing is prism neutralization. Once you know whether it's a foria or a small intermittent tropia, you will have to assess it or measure it, and that is done by your prism bar neutralization test. So as you keep your prism on one eye, in a child, it's a very good test. Look at the refixation movement on the other eye. Now, still make, that means it's not corrected. 16 prisms. Face out. Yes, basin, I'm sorry. This is an exo, so it's a basin prism. Again, there is a 80, still, yes, 20. As you keep coming closer to the neutralization, you will see that the movement will become, or the refixation movement keeps reducing. 30. Let's see what happens at 30 prism basin. It's a very small refixation. So at 35 prism, this child was neutralized. So a prism bar neutralization to estimate both your forias and your intermittent tropias. The inferences, a cover-uncover test will bring out your intermittent tropia, and alternate cover test will help you detect your foria. Do your measurements for both distance and near. Assess them with and without glasses. Always use an accommodative target, never with your pen light. And what do I mean by an accommodative target? Your two lines above your best corrected visual acuity for distance and the picture with fine detail for near. So let's go to the normative data. So the normative data for distances, you should get anywhere between 1 prism esophoria to 3 prisms of exophoria. And for near, it's orthophoria to 6 prisms of exophoria. Tropia is never normal. Any patient who has tropia will not have any binocular vision. Foria is something which you get. This is a small differentiation. Foria is when binocularity is dissociated. Tropia is misalignment even when you have a fusible target. And how do you record your findings? Cover test with correction at 40 centimeter. It is 4 prisms of esophoria. Cover test without correction at 6 meters. I'm just giving you example. If you are doing cover test with correction at 6 meters, put it CC, and this is 5 prisms of exotropia. So this is how you'll record your findings, and this is your normative data to start working on your BD problems, and then you go on to the next step. The next step is assessing divergences. So this is near point of convergence. So you do it in free space. NPC always do it in free space, and you ask your patient to keep fixing. See the visual axis aligning as the visual axis keep moving close together or moving towards each other when the target is got close to the face. Okay, so how do you record the NPC? You have to record the break point, and you have to see the normative data is less than 5 and less than 7 centimeters. Using an accommodative target or line, you have to see the recovery point, which is less than 7 or less than 10. And you have to ask the patient subjectively, are you seeing diplopia? Apart from what you're looking objectively. So what you look for objective, you see the eye moving out. What you see in subjective, Ask the patient for diplopia. Sometimes your eye will move out, but the patient will not say there is diplopia. That is because the patient is suppressing. This is how you'll record the finding. Near point of convergence, I've used an accommodative target. My break point is 6 centimeter. My recovery point is 10 centimeter. The patient has reported diplopia, and it is the right eye which I found, which was moving out first. Okay, so this is Brock string. So what is Brock string used for? Brock string is an exercise which is used for detecting or diagnosing your convergence insufficiency, as well as for exercising your convergence insufficiency. So you have 3 beads basically, and you ask the child to focus on the first bead. So when this first bead is focused, the other 2 double. So it's a form of anti-suppression also. It's not only that you can improve your convergence, but you also unravel your anti-suppression. And this first bead can actually be brought closer to improve your convergence. The second and the third bead will appear as double images. So here, if the child is focusing on the second bead, the first and the third bead will appear as double. So this is again convergence. I'm showing you how the eye is going to move out. See the subject, you're clicking the pen closer. Please do convergence test in free space. Don't use your RAF finger. And keep watching this side. Keep watching as you blink. This eye will move out after some time. When she is using it to move out, I think it is somewhere here. Let's play the video again. Somewhere here. Now she's over converging, but before that she had lost convergence. You see this eye is moving up, and then she exerted convergence again. So look for the flip of the eye. So all things that you have to know when you're doing DV assisting, and that is the point when you will start measuring your NPC. Let's go on to the next slide. So after you assess your NPC and you know your normative data for NPC, go on for your convergence and divergence amplitude. Suppose you have an exophoria for near, which is more than your distance. That means your AC by A ratio is low. You have an esophoria for near, which is more than your distance. That means your AC by A ratio is high. If you have an exophoria, which is more for distance than near, then your AC by A ratio is again high. And if you have an esophoria, which is more at distance than near, which means that you have a low AC by A ratio. And if your distance and your near esophoria or exophoria are same, which means that you have a normal AC by A ratio. You're worried about exophorias and esophorias because these are the patients who are going to have low positive fusional vergence and low negative fusional vergence. High compensating vergences are never a problem. So how do you measure your fusional vergences? Now you use step vergence or you use prism bars to measure for both distance and when I say step vergence, you're going to do in steps of 4. 4 prisms space out, then 8 prisms space out. You ask the patient blur point, break point, recovery. 3 things you'll have to ask. Blurring, when does it break double, and when does it check up? So you keep doing, you do base out, you do base in. So this patient is still having a single image at 20 prism base out. So base out means it's your positive fusional vergence. 25, yes, still single. 30, she starts seeing a little bit of double. And you can also that this eye as short term. It's moving out. So she's also reporting double, blurring or first double, and then it's also moving out. Again, subjective as well as objective. So again, you will do your base in, which is your negative fusional vergence, in steps 4, 8, like that, until the patient has blur point, break point, and doubling. So what will you do? You cannot do step vergences on tropias because you need patients who are able to fuse. So tropia, patients with tropias, manifest tropias will not be able to fuse. So any patient with only phorias or no manifest tropias, you can try your fusional vergences. You do it for both distance and near. Look for the flip of the eye. That is an objective science. Always do your basin. Though I showed base out first in my slides, always do in basin first before you do base out. This will avoid your prism adaptation. And these are the normative data. I'm not going to elaborate on this. This is there in any textbook on any this thing. You can get these normative data. But all that you have to note it, you have to know the blur, the break, and the recovery point. And there is something called as the shared criteria, which you have to understand. A patient will have a comfortable binocular single vision only if the break point is twice that of the fovea. You have a patient with an fovea of, let's say, 10 prisms. The break point should be 20 prisms. Only then the patient will have a comfortable binocular single vision. These are small points which will help you to understand whether your patient is having a binocular vision abnormality. So the next thing is accommodation assessment. So what do you assess in your accommodation? You have to look at amplitude of accommodation, which we refer it as AMS. You have to look at relative accommodation. Relative accommodation is basically assessed binocularly, negative and positive. Positive, when you're assessing positive relative accommodation, you use minus lenses in steps of 0.25. And when you assess negative relative accommodation, you're assessing with plus lenses in steps of 0.25. Negative and positive both will have about minus 2.5 plus 2.5 is your normative data. You assess your accuracy of accommodation by using MEM cards and performing your near or retinoscopy or dynamic retinoscopy. And in this, you see whether the patient has lag of accommodation or lead of accommodation. A lag means accommodation insufficiency. A lead means there is accommodation excess. You look at accommodation facility using your flippers, and that will give you your speed at which you accommodate. And there is always a link between accommodation vergence, which you can assess by using your AC by A ratio. So how do you check for accommodation amplitude? So again, you can use your near vision chart. Bring it from about 40 centimeters distance. Use N6, bring the skin closer and closer. What is this? This eye is accommodating. The patient is able to read the N6 target at a close centimeter of 10. But see this eye. When this eye is accommodating, this eye should converge. So that shows that both eyes are actually involved in the phenomenon of accommodation. If you don't see the eye under your cover converging, that means this eye has stopped accommodating. So this is a small tip to assess whether your accommodation is being exerted or not. The same thing you can do with your RAF ruler also. I use any of the things. You can use RAF ruler or you can use your near vision chart. Convert your centimeters into diopters. The only advantage is your RAF ruler will give you it in diopters itself. You measure the amplitude of accommodation in diopters and record in each of the eyes. You have to do this test monocularly as well as binocularly. So if I am going to record it monocularly, then what is it in the right and left eye? And binocularly, what was your amplitude of accommodation? Always use the patient's glasses before you test your amplitude of accommodation. And one important point is you need half your amplitude of accommodation to be in reserve if the patient has to have clear, sustained near vision. Okay, so there is a formula called Offsetter's formula. Using this formula, you can estimate whether the amplitude of accommodation is normal or at least minimum that is expected for age. And any child with less than 12 diopters of amplitude of accommodation is clearly abnormal. So this is just the RAF ruler. Again, this test is showing the amplitude of monocularly. I've closed the other eye, but the other eye is converging. This eye is reading the print. There is a small box on this RAF which will have the test types. Give the small test type and you according the near point of accommodation. And you also get the amplitude of accommodation. Go to the next slide. So inferences, do your NTA at least 3 times. Compare between the two eyes. Anything of 2 diopter difference between the two eyes is abnormal. The N5 print should be really clear and not really clear. What is acceptable is really clear. If you have a sustained blur, then that is taken as the end point of measurement. Bring your target closer slowly. Don't bring it in a very fast speed. You have to give time to accommodate and observe the eye under the cover when you're doing NTA monocularly. Is that eye converging? If that eye isn't fast, that means there is a strain. The patient is using an accommodative strain. That is why it's over converging in the other eye. If the eye visits out, that means the child has stopped converging and there is no longer any accommodation which is being exerted. Okay, next we are going into AC by A ratio. The simplest way to assess your AC by A ratio is to use your flipper. Let the patient wear his habitual correction and use a +1, -1 flipper. This is the fastest and quickest method in the OPD to assess your AC by ratio and do your cover test. With a -2 diopter sphere, if the patient has a phoria of 4 exo, you're using your +1. Now you're getting 8 exophoria. And then you're using your -1 flipper and you're getting orthophoria. What is happening? The 4 exophoria is changing by 4 prisms when you're relaxing accommodation, and it is changing again by 4 when you're exerting accommodation. So now your AC by ratio is 4:1. So it's so simple. Don't go for any of the big tests which your textbooks give. Use your accommodative flipper of +1, -1. You ask the patient to use glasses, give a target, and you measure your AC by A ratios. As simple as that. Let's go to the next. Accommodative facility. I've already told you what does accommodative facility measure. It measures your speed of accommodation. How much fast can you exert of accommodation? How much fast can you relax your accommodation? So you can do it both by monoocular and binocular method. Use your -2 plus. Start recording. 1 will be 1 -2 and plus. Whichever you get, find I'm not going to go to the end of it. So this patient suppose had 22 labs totally. Divided by 2, it is around 11 cycles per minute. This is how you measure. The same thing you can use binocular accommodative with your binocularly doing your -2 and plus. And again divided by 2, your cycles per minute. And one more thing that I'm not demonstrating is your fusional version. So instead of using your +2, -2 for accommodation flipper, use your prism flipper. You will have 12 prism, 3 prism. 12 prism base out and 3 prism base out. And again, assess your number of cycles per second to find out your fusional versions facility. So accommodative facility, you do it both monocularly, binocularly. You will also do your fusional versions facility. Anything which is 8 cycles per minute ±2 is normal. If you have a low facility on both monocular and binocular, it means that your child is having an accommodative problem. If you have a low facility only in your binocular facility, it means that you have a vergence problem. Is that clear? So after finishing accommodative facility, you go for your cover test to find out your incomitant phorias. Phorias need not be comitant. Watch this. I'm doing a cover test. Oh, I'm sorry. Okay. Now the good eye is fixing. You remove the cover from the abnormal eye. There is no phoria. I'm going to shift the cover to your good eye. Your abnormal eye is fixing. See, there is a phoria. There is a larger phoria. So this is an incomitant phoria, and what you're getting is primary versus secondary. So what is this patient have? Let's go to the next one. Look at the motility. When you get incomitant phorias or incomitant tropias, for that matter of fact, anything incomitant, the next thing that you will assess is your extraocular motility. Now see the motility. This side, what's this side has not done. So what is this patient? Patient has advanced retraction syndrome in the left eye, but it's an orthotropic advance. That is why the patient looked straight, but still you had an incomitant phoria on your cover test. So do your cover test to find out your incomitant phorias. The next is angle kappa. Before you assess your extraocular motility, please look at angle kappa. You do it each eye, occlude the other eye, find the torch and see where is your light. Slightly temper, just a small tad temper. Do it each of the eye. Then you can assess whether there is a abnormal angle kappa. See this patient, he has a large positive angle. Do the cover test, shine the torch. Now I'm doing it both eyes, then I cover the left. He's taking it. Where is the right? So much. At the end, he has a large positive angle. We are just looking at the clinical sides. Don't bother what is causing large angle. So this is again another large positive angle kappa, bilateral positive angle kappa. You can have unilateral also. Please remember, these things need not be symmetrically present. You can have a positive angle kappa just in one eye also. So do a cover test, shine your light and see for the positive angle or negative angle kappa, whatever it may be, what was demonstrated. You don't get movement on a cover test, but you have decreased vision in one eye. So what do you suspect? A monofixation syndrome. So what should you do next? You have to go for your 4-prism base out test. Watch this. There is no movement on the target. Always give a target. And I'm taking all these videos close to the face, so you can't see what is the target I'm giving, but please give an accommodative target. There is no movement on cover test in the eye. But let's do the 4-prism base out. There is a refixation. I'll repeat it again. 4-prism base. There is a refixation. Do it in the other eye. There will be no refixation because it's falling. The image is falling inside the suppression photo. You will not have a refixation. So the 4-prism base out test in the right eye of this patient is positive. This child has a microtropia or a monofixation syndrome. When you see monofixation syndrome, the next test that you should do is birth for dot for near. Watch this child. He will say, when I keep the torch a little further away, only 2. See when I bring the torch. So he says, I see 2 and I see. He is fusing all the 4 birth for dots. So what is he doing? He is fusing because as I bring the torch closer, these lights are falling outside the suppression spectrum. Not be able to fuse the distance birth for dot. So this is again another interesting test, which you do for microtropia. Motility pattern. How do you assess the motility pattern? Use your torchlight and assess the motility. Don't take it too far away. You have to observe the light reflex in both your eyes and see it in an edge pattern. See how beautifully the eye is pursuing the light. So the entire motility can all gentle simple maneuvers to bring out your abnormalities. And if the patient has double, use the same torchlight. You will be able to watch this patient. What is he saying about the double? The most important thing is the farthest image belongs to the abnormal eye. I hope the videos are helpful as well. There's no double in this. No double here. No double. No double. No double. That's double. I've lowered the torch. He has double in to down. Says there is double in the left. The double is increased in this. I'm closing. Says when I close the left eye, the new image disappears. And I asked him a question. If the new image was farther away or closer? He says it was farther away. This is a eye. This is the eye which has the abnormality because the image belongs to this eye and it is also farther away and it disappears on cover test. So you can assess your diplopia even before you're doing your red-green filter test and diplopia assessment with just a torchlight. You don't need any fancy tests or fancy things to bring out these subtle problems. So use an accommodative target, check the patient's ability to fixate, practice estimating deviations, do your cover test at 6 centimeters and 40 centimeters, sometimes even at intermediate distance. Measure the quantum of phoria. Is it equal in each eye? And what is the speed of recovery? And cover your eye at least for 4 to 5 seconds when you do your cover uncover test. If you don't get a movement on cover test, please do a 4-prism pace out test. And your tips in motility is observe your pupillary light reflex, look at angle kappa, move your torch slow. It's good to have a pointed torch, but most of us don't have that kind of a torch, but a pointed torch is much better because the patient will be able to fixate on it better. Repeat your motility test at least 2 times. Do your cover test as you're doing your motility test in the 9 cardinal positions. And the farthest, in case the patient has diplopia, the farthest image belongs to the underacting muscle. And move your torch up and down to assess for patterns. Test for suppression, yes, you have to do that. This girl does not have suppression. She sees all the 3 targets. She says, I see all the 3. But this particular child will see only 2. Watch. I see only these 2. So with the suppressing, doesn't see this. That means she suppresses the red eye. She sees the circle in the green, she sees the central circle, but she doesn't see the circle in the red. She suppresses. So you need to look for tests of suppression too. Okay. I think that's played it. And then this is a small video on stereogram. It's just you use your polarized vectographs. Now, why I'm just showing you this is you can use your polarized vectographs with your polarizing glasses to also treat your patients. These vectographs can be used for improving convergence and divergence. So we'll quickly play this video. So all these subjects are my students and some of them are patients. Is my postgraduate student. So you have Polaroid vectographs which you have to place. You have a panel on which you place these vectographs. The subject using polarizing glasses over the glasses. It has a refractive error using the glass. You have to align these stars. Doing it. So demonstrating her. You will see all these kernels and this popcorn, and you have these vectographs are how much ever you can still maintain the 3D and bring it also. So this is how this is the exercise option apart checking abnormalities. Okay, skip this video. We'll go to the next one. So you
Manjula, we are running short of time actually.
Yeah, last 2 slides.
Oh,
so
thank you.
Your sensory fusion with any of these stereopsis tests And once you have assessed your patient, you know what is your patient suffering from. Is it an insufficiency of accommodation, ill-sustained accommodation, infacility of accommodation, excessive accommodation, or is it a convergence problem like excess or insufficiency, divergence excess, basic exophoria, or is it a combination of problems like a fusional vergence dysfunction? Once you've made your diagnosis, your treatment becomes easy because you can refer your patient to the orthoptist or optometrist to treat your patient. Thank you. Thank you very much for your patient hearing and for the opportunity.
Thank you very much, Dr. Manjula. And it was a very informative and exhaustive session that you have taken pains to give us all your videos. I request the participants to put your questions in the chat box, and we'll take those questions at the end of the session if there is time.